Maternal Child Health Fellowship at the University of New Mexico, and shortly thereafter rejoined us here in Santa Rosa, where she's currently our Assistant Program Director. Was the Maternity Care Director here at our residency until 2021. Notably, Erin is the founder of our New Beginnings Clinic, a really unique, incredible place for pregnant people to get exceptional, loving, compassionate care when they have various life challenges. She was also the founder of our Women's Health Procedure Clinic, still actively involved in as OB faculty here at Santa Rosa Family Medicine Residency, and just keeps going with Dr. Lund, decided that that wasn't enough and recently became board certified in addiction medicine. And she's one of the 2 founders of our new addiction fellowship that will be starting this fall that just accepted its first 2 fellows. So very exciting stuff. In her spare time, Dr. Lund also is on the board for an international nonprofit that's dedicated to improving the health of families and communities by catalyzing sustainable, locally driven work called the Minga Foundation. And if you haven't ever heard of it, take a moment and Google it, M-I-N-G-A. It's incredible. And for those of you who attended last year, you'll remember Dr. Lund's excellent talk on substance use in pregnancy. And today, Dr. Lund will be talking to us about perinatal mental health. So Erin, please take it away.
Thanks. And are my slides showing up correctly? You just see the main slide?
No, we're seeing your next slide too.
Okay. Let me try again. Sorry.
So it worked the first time when you right clicked.
Right. Yeah, I'm just, oops. Just to go through the process again. Oops.
Now it's working.
Is it? Well,
we don't.
Hang on. All right. I think now it's working.
Yes.
You just see my main slide. Okay. Thank you, everyone. This is my second most passionate topic, and I really think a huge part of what I do in my clinical work day to day is handling perinatal mood disorders. There's so much overlap with substance use disorders, with a lot of pre-existing mood disorders that lead to substance use disorders, and then substance use that can induce mood disorders. Really a lot of commonality in people who've experienced a lot of adverse childhood experiences and traumas of various types. And that's a lot of what we do in our New Beginnings Clinic. And now as a lot of those patients we've taken care of have kind of graduated from our New Beginnings program, has become really the bulk of my continuity family medicine care practice. So this is a topic I'm really passionate about. I will point out for those who aren't aware, I sort of reference in my talk 2 recent ACOG clinical practice bulletins that just came out last year, clinical practice guidelines. This is the first time ACOG has really updated their practice bulletins on this topic since 2008. So the first time since I was a resident that they've actually updated on this topic. And I have to say they did a really fantastic job. And I'm going to highlight some of what for me are even sort of practice changing emphases on how we treat perinatal mood disorders. So check those out. Those are from last year, and I have the references in here. So we're going to talk about the evidence that links perinatal mood disorders to poor obstetric and neonatal outcomes, thinking of that as an important exposure we need to be screening for and working to mitigate. How do we recognize mood disorders in the preconception and early pregnancy periods so that we can treat them early and, again, reduce that exposure to that developing fetus and that infant? And then I'll go through evidence-based treatment options for mood disorders in pregnancy and lactation. Just thinking about the impact of this problem, 500,000 pregnancies a year in our country are complicated by mood disorders. Nationally, they say 1 in 5 pregnant persons will be diagnosed with a perinatal mental health condition. If this feels low to you, which to me it does, because I see a sort of high-risk subpopulation, but I think if you work in a marginalized community setting, community health center, taking care of folks who are structurally disenfranchised, those rates are probably double at least. And treatment levels are sadly lower, and screening is sadly lower in those populations. If we look at actual diagnoses, when we talk about anxiety, depression, and bipolar, anxiety disorders are actually the most common, affecting up to a third of those with perinatal mental health. Or sorry, a third of pregnancies will have some sort of anxiety disorder, and that's all encompassing, including generalized anxiety, OCD, PTSD, and then specific phobias. And obstetrical trauma represents a major driver of a lot of anxiety in the perinatal period. And then major depression being the next most common, anywhere between 14 to 23%, again, depending on what study, what population are you looking at, sometimes higher. And there's a very high rate of comorbid anxiety and depression. So really we should be screening for both. And ACOG now very clearly says, don't just screen for depression, you need to screen for anxiety disorders as well. And then bipolar disorder affects between 2 and 3% of our pregnant patients, and often mimics unipolar depression. So because bipolar patients are more likely to present with depressive symptoms in pregnancy, you have to be on the watch for bipolar symptoms or histories that might indicate that this patient actually has bipolar disorder, because the treatment is very different. And I'll have more about this as we go along. We know that perinatal mental health conditions are really under-recognized and undertreated. A study showed that less than half of antenatal cases are recognized, and only 30% of postnatal depression is recognized clinically. And then even smaller percentage, only 14% get treatment in pregnancy and 16% get treatment in the postnatal period. And those are really, really low. And then even of those who get treatment, single digits that get into remission because of the treatment we're offering. So this is, I think, why ACOG is really elevating the importance of treatment in their recent clinical guideline, because we have a lot of work to do. Suicide or overdose that's either related to depressive symptoms or substance use disorders is the most common cause of perinatal mortality in the US. 1 in 4 maternal deaths in our country is related to either suicide or overdose. 1 in 4. So all of these are considered preventable. Some risk factors for developing mood disorders in pregnancy are younger patients, patients with an unplanned pregnancy, those who've had prior adverse obstetric outcomes. So your patient with a really complicated birth history, preterm delivery history, baby in the NICU, prior stillbirth, those patients are higher risk, and we should be more attentive to screening them and early treating them through their pregnancy. If there's disordered sleep, that is a significant predictor of developing mood symptoms. Being active in the military or a veteran is a very high risk factor, which I wasn't aware of and wasn't on my list of items. So I'll be thinking about that going forward. Any history of substance use, again, there's a lot of overlap between SUD and mood disorders. Being involved in the criminal justice system, sort of, again, a marker of all those things, plus also often social dysfunction and risk, having low perceived social support, being exposed chronically to systemic bias or racism. There was a study that showed people who self-reported experiencing racial discrimination in the year prior to their pregnancy, 50% of them evolved into a mood disorder during their pregnancy. Having a history of sexual assault or intimate partner violence is also a big predictor. And really any adverse childhood experience, as we know in all adults, predicts a likelihood of mood disorders. So anything you've had personally or family history is also very linking. So we should be screening. ACOG very strongly is now saying screening for depression and anxiety, and this should occur not just in the pregnancy, but ideally preconception. So any sort of woman exam, PAP visit, like those are great opportunities to screen. Definitely at your initial OB visit, and then also later through the pregnancy and at the postpartum visits. So we've been under screening, we've been underdiagnosing. Let's get better about this. It should be structurally set up in our clinics to be doing this. In California is the law that we have to be screening for depression in particular, and both in the prenatal and postpartum period. And that's been in fact since 2019. US Preventive Services Task Force said we need to do this. Yet we know if you're not white and if you have Medicaid, you're much less likely to be screened and also less likely to be offered treatment. We should be using some sort of validated screening tool for depression, anxiety, and also bipolar. And we'll talk about that, how we screen for bipolar a little bit later. So different tools that have been used and validated in pregnancy for anxiety is either the GAD-7, which is a 7-question self-report questionnaire that can help identify symptoms of anxiety, or the STAY-6, which I hadn't heard about before, but it's State Trait Anxiety Inventory, also a short questionnaire. Either of those can work for screening for anxiety. And then really either the PHQ-9 or the Edinburgh Postnatal Depression Scale, they are equally validated. The EPDS does have a few more anxiety type questions. So if you use that alone, you may pick up a little bit more of anxiety, but they have similar sensitivities and specificities in perinatal populations. And again, a positive screening questionnaire isn't alone enough to make the diagnosis. You need to follow up with questions around the type, frequency, and severity, and also duration of their symptoms to truly make a diagnosis. And important to think about recent stressors that may be leading to some situational symptoms that don't need medication, right? Because this is like, how do we resolve this situation that's creating stress? And also screening for substance use that may be linked to or triggering some of the symptoms. And then any positive response on question number 10 of the Edinburgh or question number 9 of the PHQ-9 that relates to thoughts of self-harm needs close follow-up. Again, suicide, 1 in 4 maternal deaths is related to either suicide or overdose. So we need to assess access to lethal means, actual intent, and any plan, and then assess their likelihood of suicide. So it can be useful to use a severity rating scale to help elicit the likelihood that this person's at risk and how emergently do you need to get psychiatric evaluation. And then also assess for protective factors. So having a spouse who's supportive, having parents that are alive actually is protective, having children already is protective, and having some grounding and spiritual beliefs have been shown to be protective. And conversely, active intimate partner violence is a major risk factor for actually completing suicide, and we should be screening for that as well. If you notice significant anhedonia, so there's no like desire to get out of bed and do things, and sort of lack of self-care are also highly predictive of a suicide attempt in the presence of suicidal thoughts. And so we should be kind of attentive to that as we're interviewing somebody. How do we prevent this? So there's been a lot of interest in how do we prevent perinatal depression. We can actually increase someone's support network by home visiting nurses or a midwife that's doing sort of home visits, assessments, connection with resources, and that can reduce the chance of having depression. Peer support by telephone has also been shown to be productive. Physical activity for someone already experiencing depression symptoms has been shown to reduce their depression scores. And then this is now actually a USPSTF grade B recommendation, is to offer therapy in the antepartum period, either in a group therapy setting or individual therapy setting, because it reduces the likelihood of postpartum depression or depression symptoms by 40%. And that's in people who are high risk. So not having any depression now, but you identify they're at risk. Maybe they had it their last pregnancy, they've had depression in the past. They have lots of social chaos. Starting therapy antenatally can really significantly reduce the chance that they develop it. This is our whole model of New Beginnings, is we have a therapist that's working with us that really meets all of our patients. So even if they don't have needs right now, we can be doing some of that process and helping reduce this risk of developing significant depression. And then also a study looked at starting sertraline after 20 weeks gestation for people at high risk of sort of postpartum depression, and they reduced the rates to 7% compared to 50% in those who did not start sertraline. And again, this is a high-risk population, so think about that. Again, this might be kind of a practice changer. Don't wait for those symptoms to develop. We know those symptoms are a significant risk to the pregnancy and the infant. Start treatment. So why do we want to treat? Why do we want to prevent this? So again, think about depression and anxiety and all mood disorders as a significant exposure. When we don't treat, we have increased rates of low birth weight, preterm birth, SGA, and actually for depression, we see less fetal heart rate reactivity. the exposure of depression is strongest if it's in the second and third trimester. So think about like fetal brain and when those neurons are developing and how that environment of a depressed pregnant person is impacting that brain development in that infant. We see higher NICU admissions if the child is exposed to depression in utero. We see higher levels of cortisol and catecholamines in umbilical cord blood samples and lower levels of dopamine and serotonin. So that's this environment that this fetus is developing in depressed sort of uteruses. Babies tend to be a lot fussier and more difficult to console, and later in childhood are more likely to have conduct disorder, antisocial behavior, and are twice as likely to have ADHD or other emotional problems. And then later in life, also a higher risk of suicidal behavior when you just look at that antepartum exposure to depression. With anxiety untreated, we see higher rates of miscarriage, preterm birth, low birth weight, prolonged labors. So both that like too early, but then also this like uterine dysfunction that leads to like long stalled out later labors. Operative deliveries are more common, both operative vaginal deliveries and C-sections. And we actually see abnormal fetal heart rate tracings due to maternal anxiety. So you can see D cells related to decreased placental blood flow, likely all that catecholamine surge from the pregnant person. And then also tachycardia is more common. And then that gets misinterpreted as acidosis or risk for acidosis and leads to more operative deliveries. We think of our 5 Ps of labor progression, and psyche is a big one. And if you have a super anxious birthing patient, you're more likely to end up with dysfunctional labor. There's like altered gene regulation at the level of the placenta that's likely impacting a lot of this with the preterm delivery and low birth weight. We're just barely kind of learning about the physiology of all this, but it's real. And then for children born to anxious parents, their poor adaptability, so their ability to adapt to new situations. They also have more crying and actually some like mental development changes at age 2. So significant effects both for depression and anxiety. In the perinatal period, first line treatment is really psychotherapy. If someone presents with mild to moderate mood symptoms, obviously we want to offer psychotherapy to anyone, including those with most severe, but often it's sufficient by itself if symptoms are more in the mild range. Both individual and group psychotherapy can improve symptoms in pregnancy and postpartum. And really either interpersonal psychotherapy or cognitive behavioral therapy have the strongest evidence for benefit. But we have to recognize not all patients have equal access to. It's not always possible to find a culturally appropriate therapist, particularly if you're non-English speaking or you're non-white in this country. It can be hard to sort of fit into this model of psychotherapy. And so you have to have a conversation with your patient about what they're willing to do, what works for them, what works for their life and their schedule. Thankfully, there's a lot more options for like telehealth and telepsychotherapy than there used to be before the pandemic. And really emphasizing, and the ACOG really emphasizes in their new practice bulletin, collaborative care models. So that's where you have integrated with your OBGYN care. So mental health. And so ability to do those warm handoffs, ability to refer back and forth has been shown to really improve access and reduce treatment disparities by race and income status that we otherwise see very prominently. When we think then about other treatment options, really we're relying on medications for the most part. It's important to use up-to-date resources. I really want to lift up the mothertobaby.org website. If you haven't ever looked at it, please go to it today. It's really amazing, and you can refer your patients to this website as well. Lots of information. You can print fact sheets about any exposures, medications, hair dye, marijuana, like really whatever your patient might be exposed to. And it presents it in a really nice, like patient-centered language that talks about what are the actual risks that we know, what are the risks of not treating depression, for example, compared to medications. A lot of these other resources for what I've used historically for lactation, we used to have the like Hale book that lived always on postpartum. Now they're digital and they're not free. I think they are still considered sort of the gold standard for sort of lactation resources, but the mother2baby.org has this LactRx app, which is free and links directly to their database. So that would be one that is highly recommended and free, and just to have on your phone as a quick reference point. In lactation in particular, we generally want to look at meds that have the relative infant dose that's under 10%, and those are generally considered safe. If it's higher than that, you have to really weigh the risks and benefits. Often, though, the benefit of treating will outweigh the risk in your more moderate to severe symptomatology patients. And when we do decide to use medications, we want to use the lowest effect and sort of ramp up a single agent before we add in multiple agents. So beware of the polypharmacy when we don't really know then how that impacts risk to the developing fetus. So first-line therapy is generally going to be an SSRI for patients with anxiety and depression. Multiple large studies show no associated increased risk of birth defects. If someone's on a certain SSRI or even SNRI pre-pregnancy, you generally want to keep them on what they've been on and what's been effective, rather than switching to a different med that maybe has lower risk, but then you've exposed the fetus to 2 different drugs as opposed to staying on the one drug that you knew worked for them. If you're starting someone for the first time and they're pregnant, probably either sertraline or escitalopram are going to be your first-line options. They're very tolerable compared to other SSRIs and have also been shown to be safe in lactation. So they're sort of your first or second line meds to try when you're newly having to start someone. Paroxetine, for the most part, I consider contraindicated. There have been concerns for cardiac defects, and also the withdrawal effect is more prominent, both for the pregnant person if they miss a dose and also for their fetus after delivery. So that's one I just tend to avoid these days in reproductive aged patients. Second line antidepressants, so if people are already on any of these medications, it's fine to continue them. So bupropion or Wellbutrin really is fine to continue to use. No major concerns about birth defects. Has some advantage over SSRIs for certain patients. Also can help them quit smoking if that's an issue. And then the SNRIs, like venlafaxine being the most common, one study showed increased growth restriction and another slight increased risk in preeclampsia or miscarriage. I think we see elevations in blood pressure sometimes when patients are on these drugs. So something to watch for. Maybe don't start it in your person who had preeclampsia in their last pregnancy or is high risk for preeclampsia. But really, if this is what works for them, the benefits of continuing are going to outweigh those risks. And then TCAs we tend not to use as much anymore, but if someone's on that for maybe chronic pain or sleep or whatever other condition, it's okay to continue them. Doxepin is the one in that class you do want to avoid. So anxiolytics, I know some of the things I put on here are not traditional anxiolytics, but really things that I think of nowadays we pretty much are using for anxiety. Buspirone should be your first line in pregnancy. Really no teratogenicity. There's actual studies in pregnant persons showing that it's safe. It may not be effective for everyone. I think it works best for generalized anxiety disorder. It's a BID to TID drug, which is problematic sometimes, although I definitely have patients who say they take it on an as-needed basis and find some benefit from it. So that is generally my first line. If someone has isolated anxiety and doesn't want to take an SSRI or SSRI didn't work well for them in the past, or if I need to augment their SSRI treatment, that will sometimes add buspirone. Alternately, hydroxyzine, particularly if they are having sleep issues, is safe, and also panic symptoms. So something you need on an as-needed basis, hydroxyzine can work quite well. Again, gabapentin isn't a typical anxiolytic, it's an anticonvulsant, but often we are using it for sort of anxiety symptoms, especially if there's comorbid substance use disorder or alcohol use disorder, and really weigh the risk and benefit. There's no concern for teratogenicity. Benzodiazepines, and ACOG really continues to support that we should be tapering patients off benzodiazepines if they are on them in pregnancy. It doesn't have to be rapid. Your goal is to get them off or at a very lower dose by the 3rd trimester. Intermittent use for like PRN or, in the setting of, acute opiate withdrawal, and you need to get them through that period, you can use it. No concerns now for birth defects like we used to see. The real concern is sort of respiratory depression, low tone, and sedation of the infant at the time of delivery. The neonatal withdrawal syndrome can be more severe and prolonged with benzodiazepines. So that is the main reason to get your patients off. If you're going to taper them off, it should be gradual, no more than like 10 to 20% of their dose every 2 weeks. And I'm happy to answer questions about that later. So moving to bipolar. So ACOG now very strongly comes out and says we should be screening all perinatal patients for bipolar with a validated questionnaire. For me, this is practice changing. I think I've been obviously aware of bipolar, thinking about bipolar, but not using a standardized questionnaire. And so I'm going to be looking into that following this presentation. But they sort of suggest it versus like a mandate, we should do this, but they say really, if you're going to start pharmacotherapy for depression or anxiety, you must do a screening for bipolar. And I'm going to show some of the evidence for why they say this. So there's 2 different sort of standardized questionnaires they recommend, either the mood disorder questionnaire, which like the first 3 questions of that, basically, if those are all negative, you've pretty much ruled out bipolar. And then, or the Composite International Diagnostic Interview, or CDI, which I think is also just a 2 or 3 question thing that then if there's positives in the first 3 questions goes to a more expanded portion of the questionnaire. For those in our health system, I'm going to look into next week kind of what we have available to us in our OCHIN Epic so that we can start instituting this for sure in our New Beginnings clinic, but I think to make recommendations at that initial prenatal visit, ideally. 7% of patients with depression will change from sort of just depression to actually bipolar. So in this whole period of perinatal, it's one of the biggest risk factors for patients having their first episode of mania. So pregnancy itself is a trigger. That perinatal period represents the highest risk time in someone's life to present with symptoms of bipolar. So again, 7% of our patients who are depressed will actually evolve into mania, so actual bipolar. And then if we look at people who have a positive perinatal depression screen, if we also do a screener for bipolar at that time, as many as 1 in 5 will have positive answers on that bipolar screen. So we really should be doing these simultaneously to identify those patients. And again, if you are bipolar, your perinatal episodes will tend to be depressed, so they can masquerade as unipolar depression. And if we don't treat, a third will have symptoms antepartum, but 2/3 will have symptoms postpartum if they're not on treatment. If we keep them on medications during the perinatal period, that reduces their relapse rate down to just 25%, which is still really high. And so these are high-risk patients that need to be monitored closely, generally with our psych colleagues. Postpartum psychosis is one of the things we worry about. Bipolar is the single greatest predictor for postpartum psychosis. A history of that or a history of mania postpartum is likely to recur in 1/3 of patients. Starting lithium immediately postpartum is the best evidence to prevent this in highest risk patients. And so we really should be thinking about kind of intrusive thoughts, though occasional intrusive thoughts is really common. 70% of our patients will have those, but really it's how frequent and how severe are those intrusive thoughts. And that's kind of these are some examples of questions that can help us elucidate these in our patients. Antipsychotics and pregnancy lactation. ACOG is very strong now in stating that we should continue mood stabilizers or antipsychotics in pregnancy with the exception of valproic acid. The risk of recurrence is just too high when we take people off their meds. And really shifting like more now, the 2nd generation antipsychotics are generally going to be our first line for both mania or psychosis. We have to worry a little bit about weight gain and GDM, but we're going to screen them like we screen all of our patients. Of that class, quetiapine has the lowest transplacental passage, so we often are choosing that, but can be more kind of risk for metabolic syndrome than other ones like the lurasidone, but it's just so new that we don't have as much safety data on those newer drugs. Clozapine is one in that class we should not use in breastfeeding. And patients on long-acting injectables, generally, we have to worry about them metabolizing those drugs faster in pregnancy. And so weighing benefits of continuing an easy-to-use medication in pregnancy versus converting them to an oral medication. We can still use our first generation's antipsychotics like haloperidol. There's lots of data on them, but concerned around like extrapyramidal symptoms and dyskinesias for both our patients and their babies. As far as mood stabilizers, valproic acid is the one that really should be discontinued. High risk of neural tube defects, even if you replace with folic acid, also cognitive delays in the baby, craniofacial anomalies. Lithium, this is something that ACOG is now less strongly saying we should avoid. So really having a thoughtful discussion, consulting someone's psychiatrist, weigh the risks and benefits of exposure, especially if they've already been on it in the first trimester. There's probably no real benefit to switching them at that point. So think about this ideally preconceptually if you have that opportunity. If there was exposure in early conception, you need a detailed anatomy ultrasound and ideally a fetal echocardiogram if you can get that where you practice. And then you have to monitor the levels closely and generally up titrate during pregnancy, and then very carefully kind of rapidly down titrate postpartum to avoid lithium toxicity. Lactation can be challenging with lithium because it does pass to the infant and you actually have to monitor the infant levels. So often the benefits of lactation may be outweighed by the risks. So something to be aware of and cautious. But again, and this is the best treatment for your patient to stay stable, the benefits are probably there to continue. Lamotrigine or Lamictal is really the safest available mood stabilizer, best treatment for bipolar 2 without known major fetal anomalies, and is safe to continue in lactation. You have to titrate very slowly. So again, this is good to start in a preventative way for someone you're worried about symptoms developing postpartum. You can get agranulocytosis. I've seen patients get neutropenic as sort of the start of that. And so you do have to monitor CBCs periodically as you get to higher doses. And then lastly, postpartum depression is very common. If we look at just the first 3 months after delivery, almost 20% will experience that. If you go to a whole year after delivery, 37% of patients will experience some depression. Lots of impact on how that person is able to parent. If they're experiencing depression, parenting behaviors are different, less engagement with their infant, less praise, less active playing with their infant, more likely to stop breastfeeding, and then less likely to attend postpartum visits. So that's for me is always a red flag that I really need to be screening for depression if someone's missed multiple visits with their child. It has very clear impacts on child development, impacts attachment, impacts child social interactions, slowed language acquisition, IQ is impacted, more hyperactivity or impulsivity, and the number of depressive episodes, so that exposure correlates with the severity of the child's symptoms. Think about undertreated or untreated parental mood disorders as an adverse childhood experience with potential lifelong impacts for that child. Again, just to summarize, like meds and lactation, generally, if it was safe to use in pregnancy, it's safe to use in lactation. The exposure in pregnancy to the fetus is greater than whatever exposure there is in the breast milk, with a few small exceptions. SSRIs, of the SSRIs, sertraline is the best studied and really minimally enters the milk. I reassure my patients who are nervous about that it really doesn't seem to go to the babies through the breast milk. Some concern for fluoxetine because of its long half-life, but doesn't mean you need to stop it. And SSRIs are as effective as cognitive behavioral therapy to get remission. If someone has moderate to severe depression, you really should combine those two treatment modalities. And then treat for 6 to 12 months. This is what I tell my patients when I start treatment. I say, you need to continue this through at least 6 months. Think about it through that first year of life. If you stop it too early because you're feeling better, you're more likely to have a recurrence of your symptoms. Really quick, just new therapies that we're seeing. Probably you've heard about this new injectable medication, brexanolone. It's a different type of medication. It's a allopregnanolone hormone analog, affects GABA levels, and has had some promising results for people who have sort of refractory postpartum depression. 7 out of 10 patients went into remission in a very quick period of time. Downside, you have to do it as a 60-hour infusion, so requires hospitalization with continuous monitoring to get it. Super expensive, right? Not very accessible to most of our patients. Interesting, like in the placebo arm, there was significant improvement as well, because getting 60 hours away from your baby in the hospital is actually really therapeutic. So think about, having someone take the baby overnight so they can get some sleep may be sufficient as a first line, but this is an option, and ACOG still lifts this up as something we should consider. Lastly, just think about, again, the exposure of untreated mental health disorders and the treatments themselves as things we need to monitor those babies closely for developmental milestones, offering early intervention for any high-risk baby, which is really anyone who's been exposed to either the mood disorder itself or potentially medications, and really to assess parental mood and also substance use at every baby visit. Plug for family medicine and a plug for doing dyad care, where you have both the postpartum patient and the baby at the visit at the same time. It saves you time because you already have to screen. If you're seeing the baby, just do it in one visit, and then you can bill for 2 visits. In summary, we need to be screening more. It's super important. We can improve obstetric and newborn outcomes, refer your high-risk patients to therapy, and consider prophylactic therapy or medication for those at high risk. And poorly controlled mood disorders is a harmful exposure by themselves and generally much more harmful than any treatment we will offer. Avoid valproic acid and carbamazepine in people with reproductive potential, and discuss pros and cons of stopping lithium in those who are on that. Here's some resources. I'll just leave that up. You have these resources, know them in your clinic. There's national hotlines, texting options. And then for providers, there's this free psychiatric consult line that you can talk to somebody. The mothertobaby.org is great. And I frequently use the live chat feature on that website to ask about meds I'm not so sure about, like newer meds that there's just not data. Hey, what do we know about this? And you'll get a whole, they'll search their database and give you a whole summary of what we know.
Erin, that was just fantastic. As always, you are such a treasure for our community and the greater community. So thank you as always. I just saw a question come up from Lee Valspinosa about group visits. I think in the interest of trying to stay on time, I'm going to encourage Erin, if you have a few minutes, to stay online and answer a few things in chat. But I do have to ask one question. Postpartum depression, sertraline, I think that's one that most of us use frequently. You said 6 to 12 months. Personally, I've gotten away with much, much shorter courses. I present that to patients, sometimes on the order of weeks or even a month or two. Any thoughts about these shorter, the use of for shorter duration?
You can get them into remission, but they have a very high chance of recurrence of their symptoms in that first year. And again, I think about that first year for that child's development, and that infant bonding is so crucial. So really, that's the argument to continue for longer periods of time. That's what the data shows.
All right, well said. And then the last thing I think, with just that number, we always talk about the 4 horsemen of obstetrics, about hemorrhage and infection, but 1 out of 4 maternal deaths, suicide or OD, just an absolutely frightening number. So the information you just provided us today is super valuable for us caring for what is clearly the leading cause of pregnancy-related death.
Personally, have lost at least 7 patients over the last 5 years related to those things.
Oh my gosh.
Homicide and domestic violence being up there as well. So it's tragic. Every single one is tragic. And anything we can do to prevent those is necessary.
Great. Thank you so much, Erin. We're going to jump right into our next talk.